because he is continuing a tradition that was started years ago. And Chandra, you'll remember from our meetings, Dick Briggs from our club worked so hard with Larry Rhodes out at airport. And they began these efforts that were, as you were already doing in Thailand, that have grown and had such incredibly positive impact on places that we never believed that we would be. And now I wanted to just share, we've had this group of these international clubs come together, and it started when Dick and Chandra and all of us were meeting kind of informally, and we started putting our heads together as the grant process changed, and thought we could do a lot better if we pooled our money and were able to, on a very routine basis, honor all the club's projects, but be able to give that much, like about $8,000 to $10,000 more every year for each club. So we've had this collaboration of the South Valley Rotary Grant Committees going on for at least 6 or 7 years, maybe even longer. I'm not even sure. But I remember when we drew the first hat down at one of the big meetings down in wherever it was like south of here, and it was a start on a collaboration that we don't necessarily get to talk about very much at our club meetings, but the way it has evolved in all of the countries where we've had these relationships. And like, for instance, Tom English's work in Nepal, and all the things you've done in Thailand, and then all the work that Larry and Dick started in Uganda, which is being continued. Steve Marks being very involved with what their club has brought in terms of training and sharing of personnel. There has been an enormous kind of, I would say, step forward in international work for Rotary. It's not always been easy. We've had a lot of challenges with Rotary International in terms of the grant process. And we've had, like, for instance, in Uganda, a lot of challenges with the government slowing things down. We've always had to be pretty flexible with our South Valley Greater Group, because we've had to modify what years we were going to do things depending on what goes forward. It's a real frontier in terms of working on these projects, especially in rural areas. For instance, in Uganda, the bigger clubs in the cities, in Tebi, and so they don't have as much connection with the rural areas, and they don't have as much incentive to really support them. But that collaboration with them and the government has allowed us to continue in this area that Bob is going to talk about today. And now they have places where they have actual clinics for physicians' assistants to come. They have all sorts of good water systems in place that has evolved. I can't give you a whole rundown of all of them. I need Larry and Dick here to summarize all the changes that have happened in Aurora, but it is amazing what we've accomplished. And it's not just in that part of this is in the eastern part of Uganda. I've run into people in Western Uganda where other Rotary clubs from the Southwest have worked with Scott Kellerman, who is a man who's been there next to the there's the reserve for all the gorillas, the mountain gorillas down there. And they have put in clinics and had tremendous success actually working with shaman in the area to figure out how to treat people for tuberculosis and how to deal with AIDS, and also putting in neonatal units. So those kinds of efforts that have been continuing from Rotary decades are really, I think, having an incredible impact. And today we're very honored to have Dr. Robert Nichols, who hardly needs much introduction. He's one of the most famous and most beloved doctors in our community. That's true. Your name is well known. And the work that you are doing and continuing with downtown there is just an incredible example of what continues to grow, the seeds that are sown and how you're doing it. So I think everybody wants to welcome you. Cottage Grove will certainly identify with all you're doing, and we're delighted to hear you today.
So it's my great pleasure to be here. And actually, I know one of your members well, Kathy, who is here. She is an old colleague of mine. And actually, I attended one of your fundraisers with my wife years ago at Kathy's invitation. We probably drank too much wine and bought too much dessert, but it was a lovely time. Thought I'd have to give a little background, but Linda, you've really given the background mostly for our project. Larry Rhodes, which I assume many, if not most of you know, has been involved in this area of Uganda for 10 or more years. Initially started with sanitation and water projects and then evolved into regular medical teams going annually, and as well as providing some support to this group of clinicians on the ground called the Rural Health Team in between the annual visits to the Tororo District of Uganda. So our project is located in the east of Uganda in a relatively rural area. And if I made co-host, can I share my screen? Because we do have a little PowerPoint. Can everybody see that? Yeah. So as you can see, and again, it's my great pleasure to meet with you today and kind of tell you about this project. And Linda brought up water project, and Larry has been very successful with a water project, unfortunately not in this specific area. So we're also going to mention a kind of a companion project we're trying to get off the ground that has to do with water as well. So this is our global grant, and one of the reasons I'm excited to say something about it, it has finally gotten the district approval in Uganda. And so it is now on to TRF, and we'll sit on the edge of our seats about the TRF process, because it's been a struggle for some of the other clubs in the SVRGC. I'm relatively new to Rotary and to the SVRGC. I've been a Rotary member now for over 2 years, will be 3 this spring. And I'm now chair of our international committee, and that's how I got into this role with this grant. I do have a long history with Larry. Actually, I met Larry years ago because our genetic counselor in our office here in Eugene lived with Larry. We rented a little garage suite from Larry years and years ago. So I've known Larry and Marianne for quite a while. Anyway, back to our project. So this quote is is kind of extracted from an article that a study done in this area of Uganda. Our study in this, it's a district hospital, the Tororo Hospital in rural Uganda, identified statistically significant associations with perinatal deaths with the following risk factors: multiple gestation, low birth weight, prematurity, birth or breech presentation, cesarean delivery. And again, the article suggesting that all this information can be used to inform targeted interventions to reduce both maternal and infant morbidity and mortality. So this is one of the things that supported our focus on maternal and child health, and particularly on antenatal care. And for antenatal is confusing to some people. Antenatal is what the rest of the world refers to as prenatal care. We refer to as prenatal care. So it's care of pregnant women. And more on needs in the area. Almost a third of Ugandan children under 5 are failing to thrive. And in this particular sub, it's 41%. And this is driven by many factors, including the malnutrition, high disease burden, particularly malaria. And again, this is just another example of the challenges the mothers and children face in these rural areas. The other huge challenge is distance and access to health services. As we'll talk a little bit later, we're going to be working in 8 villages in this area, and they range from 15 to 35 kilometers from the local level 3 hospital in Tororo community itself. So as we said, this is where our project is taking place, and this is kind of a substitute picture. I'll refer to it that way. That's myself and actually the wife of a member of our international committee for Downtown Rotary. And we participated with a separate medical team going to Uganda several years in a row. And so this is a picture from that. But anyway, we are going to be working in 4 sub-counties, and I said 2 villages in each of these sub-counties, so 8 villages. And this is our work, and Larry's work in the past has been right in collaboration with the district health officer for that area, David Kumu. And Larry has worked very much in the past with the Tororo Rotary Club. And as we'll see in just a second, this group of clinicians called the Rural Health Team. So what are we trying to do with our project? So the core of our grant is to increase access to, but also quality of antenatal and postnatal care for women and primary care for their infants. So how are we going to do that? So our first area of focus is going to be access to services. And I just mentioned the distances many of these women face to get care. It's a great disincentive for regular antenatal care. It's a great disincentive for women to get to services when they have complications of pregnancy and for childbirth. So walking is one form of transportation in the area, what are called bodas or motorcycles for a relatively small free. Ambulances really are essentially not available in these rural communities. And because of the weather and the terrain, would have difficulty accessing some of these villages for certain times of the year. So we have focused on purchasing some moto ambulances, one for each of the sub-counties, and you'll see a picture of them in a little bit. We also want to improve the quality of the antenatal care that's available, and that's by introducing the use of regular antenatal ultrasound, again, to help date pregnancies and help identify some pregnancy complications. And the third focus is going to be on what we call mobilization or educational programs for villages. And we're going to work through the rural health team with what's called the village health teams. And these is basically the first level of health services in all the villages throughout Uganda. These are all volunteers, the village health teams, and they're there to do health-related initiatives, such as educational initiatives. And our focus, as we'll see in a second, is going to be, again, on antenatal care and issues related to that. And the last thing we would like to make formal, something that's currently happening informally, which is set up a clinician-to-clinician telehealth system. So as I mentioned, Larry has been going for a number of years. He's been championing medical teams going, including David Marks and Dick Barnhart from Downtown Rotary have regularly participated in those medical clinics. In this past year's clinic, which were in January and February, Dick and Larry conducted community needs assessments or community meetings with the village, 4 different villages, and that was some of the basis for our selecting our priority areas. So the rural health team, and the rural health team is going to be recipients of and also participants of and implementers of most of the activities of this project. So the rural health team is a group of clinicians that are more like perhaps physician assistants, if you will. And they have been providing some services to these villages through the use of motorcycles. And one of our motorcycles was purchased by the Eugene Rotary Club. So what we're proposing to do with this project is really build on this structure that's in place, the rural health team that has relationships with the district health officers, as well as to the remainder of the health services in the region. There would be a level 2 clinic and then a level 3 clinic, which is the first kind of hospital-based clinic, and that's in Tororo. And so here's a picture of the moto ambulance that we have settled upon. And as you see, it has a sidecar type of design. And it's available through Pulse, which is a company in Kampala, Uganda. So we're purchasing locally. They're well aware of the terrain and the needs in terms for accessing some of these villages. We looked at several of their different options, and this seemed to be the one that would fit best with our needs for those villages. And again, these will be available for transporting women to deliveries and transporting mothers and infants to appointments as needed, particularly if they're pregnancy complications. So I mentioned the second focus is on antenatal ultrasound to enhance the quality of antenatal services to these women. Not currently available even at the local hospital. We will have two rural health team midwives will be trained in use of obstetric ultrasound. Training is available at the Ernest Cook Ultrasound Research Center in Kampala, located at Mengo Hospital. And it's called a 333 training, where you have the women come and spend 3 weeks there, then they go back to their local practice sites with a mentor who goes out with them and spends 3 weeks there, and then they come back for an additional 3 weeks at the center of Kampala. So it's called the 333 program. And a third focus is going to be on providing these mobilization educational presentations in villages. And we're going to work with the village health teams. These presentations will be developed by rural health team working with the village health teams. There's a number of initiatives already available in certain aspects of, in use in certain aspects of or areas of Uganda. And our targets is going to be talking about what's appropriate antenatal care and postnatal care, family planning, spacing of pregnancies, and also prevention of violence against women. And so there are programs through UNICEF as well as through the Uganda government on family planning, prevention of violence against women, and we'll borrow from those programs as we develop our community educational programs. And the other aspect of this is we're going to talk about the use of mosquito nets for malaria prevention, and each of the women who delivers will get a mosquito net for their infant. And lastly, telehealth. And it's very clearly, it's clinician to clinician. So rural health team to clinicians either locally or internationally, that would be us. And as I'll mention again in a bit, we're interested in any physicians who are part of your two clubs might be interested in joining us. This is going to be spearheaded by Dick Barnhart, who, as I mentioned earlier, has gone with Larry for the past so many years on these medical missions and has relationships with members of the rural health team already. And he's already providing some informal consultation through email. Our plan is to make it a more formal system to set up templates for these consultations, both what's urgent and what's non-urgent. A little look at our budget, and it's just more primarily showing this to see the number of clubs in our area that have are contributing to this. So the SVRGC clubs all contribute to the one club that has the global grant that year, and that's us this year, the Downtown Rotary. In addition, the host club in Tororo contributes a certain amount. We also have two other United States clubs that are contributing, as well as districts from Petaluma Valley, California, and the Tifton Club in Georgia. So it's a multi-club project. And as I said, or should have said, because of Larry, and our club, Downtown Rotary, is collaborating fully with Airport Rotary on this project, and our intent is to collaborate next year when it's Airport Rotary's year to submit a global grant. And this just shows a kind of a breakdown of spending, and really the ultrasound equipment and the motor ambulances, as you would guess, are the big ticket items for our budget. We address sustainability through charging small fees for services of the project. This includes the clinic fees as well as the transportation on the motor ambulances. They're going to be based on what's currently sustainable in the community, which we've had the question of what happens for villagers or who are not able to pay these fees, and there is a system set up through the Rural Health Team with village leaders to help determine which families are appropriately deemed not that they do not need to pay these clinic fees. Or be on a, if you will, a sliding scale of sorts. One thing we had hopes of doing, and I think Linda brought up the west of Uganda in her conversation, at Bwindi Community Hospital, where Scott Kellerman had kind of started things off, and it's turned into just this amazing hospital with an array of services. They have established a kind of a health insurance plan for local villagers, where they pay a certain amount, which is not much more than 1 or 2 clinic visits, to get services throughout the year. And our hope is to be able to look at this kind of system in the second year of the project, when it's Airport Rotary's turn. There are a number of training initiatives. Through this, we'll be providing some ongoing support as training through our telehealth connections with the Rural Health Team and our local medical professionals. We will be Larry's going to continue separate from the grant, but the annual visits of the medical team, once COVID goes away, will continue. As I mentioned, we're going to be doing some village mobilization education about antenatal services and prevention of violence against women and things. The training of the 2 midwives on obstetrical ultrasound. And Pulse, as part of the purchase price of their motor ambulances, offers a training program on maintenance and care for the motor ambulances.
Mm-hmm. That's important.
So instead, we're partnering with Airport Rotary and all the other SVRGC clubs. And this is a big grant. It's a great challenge. And we're really building on a foundation that Larry has spent many years to develop. And it's not us, Larry, it's all the clinicians and their colleagues locally, including the district officer, who are really looking forward to this project. Right now, as it says here, and I mentioned earlier, if there are any medical personnel from either your clubs who might be interested, we'd be happy to hear from you. And at that, I'm going to switch gears completely to this water project I mentioned. So that was our global grant. What we heard from villagers was that water was a huge issue in these villages. Many of their wells were not working or poorly working. And clearly, access to clean water is a huge public health issue. Not something that we can address through the global grant. So we were trying to raise some funds to do well repair, separate but complementary to this global grant, because it will be happening in the same villages and the same sub-counties. And so this slide just presents what our goal is to raise $20,000. We estimate, and this is a generous estimate, of $750 per well. There are 20 or more wells that need repair in this area. And so that's how we come up with that dollar amount. And we do have some plans for developing a fee system in each of these areas from the villages that they would control for maintenance and repairs of those wells. So if there are any of you who are interested in this particular project, and I can leave this up, we are certainly willing to take your donation, and it would be directed to the Eugene Rotary Charitable Trust, and in the memo line on a check, if you will, it would be the Tororo Water Project. So we have now raised up to a little over $5,000, I think, on this project. So with that, I can put this back up if you're interested. I'm going to take questions.
I have a question, Robert. This is Susie Andrist. I've been involved in the SVRGC too for a while, and a number of international projects. And I'm wondering about, for this extra water well project, wondering about doing a district grant to help with the funding for that, where numerous clubs could
So,
come together.
as I said, I'm relatively new to Rotary.
Yeah.
So relatively new to the granting aspects of Rotary. As I understand it, our club is allowed 2 district grants to submit per year.
Right. Every club is the same way.
That decision is going to be made in kind of May, early June, before we need to get them together and submit them in July. And it's made by a different committee than mine. It's made by our Community Services Committee. So yes, we are thinking about that to support this project. But I don't know how it will compete with other interests when it comes to May and June.
Yeah, the way our club works is we submit one local project and one international project every year, and the priority alternates from one year to the next.
Well, that sounds great. I think I'll make that recommendation.
Okay, good luck with that.
to our club.
I have a question.
Susie kind of beat me to the punch there, but I was thinking the same thing. And if there's 4 clubs that go together,
Right.
each with one grant of 2,000,
Right.
that would be 8,000, and then it would match at 16,000.
Yeah.
Yeah.
And the bar of approval is so much lower
easier.
than a global grant.
Right. So the community needs, as I understand it, the community needs assessment is not as important. The support from the host Rotary Club is not as important for district grants.
Right.
Anita, you had your hand
Much
up.
lower bar.
But clearly the need is there in this whole sub-region. When we're talking about 20 different wells, this is, it's 20,000 or more people who are served by these wells.
I'm Anita Weiss. I'm a professor of international studies at the U of O. And I
Hi.
first of all want to commend you on the comprehensive programs that you're developing that are intertwined, your justifications for them. I'm very impressed with what you've done. And also that you've gotten a number of not only clubs in this area, but elsewhere in the United States to join in. I also wanted to respond to clarify to other Rotarians the need to charge people. I was involved in USAID's Coast Impact Project in Mombasa, and it was a huge issue of whether or not you charge people to use the health clinics, and they decided to do similar to what you're doing. They charge the equivalent of like $1 to come to the clinic, and people who can't go, who can't afford that, they get some verification that they really can't afford it. But what they found is that when you charge people, they don't come for frivolous reasons. So, I mean, I know it's always hard, especially to explain to Americans, why are you charging poor Ugandans to visit your clinic, but you have to. But great job. I don't know if I could be of any help, but we do have a global health department, global health subfield in international studies now. They're not physicians, but they're international public health experts. And so I'm happy to liaise with you on that.
Yeah. So in terms of our support through telehealth and kind of support health-wise from here to there, I'm a developmental pediatrician, so I'm not a primary care pediatrician. I see kids with developmental issues, behavioral issues, birth defects, that sort of thing, autism. But we do have a couple of other primary care pediatricians lined up to participate. Dick is an internist, Dick Barnett, or Barnhart, and I think we have an OBGYN from Southern Oregon, the Medford area. So we were trying to expand our group of clinicians as we try to set up this telehealth more formal system.
Thank you for that, Linda.
Well, I'm just thrilled with all the progress that you're making there, and I'm very happy to hear, Bob, that you're aware of Scott Kellerman's program on the other side of the country because he's dealt with so many of these same problems, not severely with the water, but the nutritional issues that he's been confronted with. And I got to visit that years ago, and I was really impressed with the fact that basically, in order to help the families give better nutrition to the kids, they actually invited the families to come and live near the clinic, and they taught them how to grow vegetables and better food, because a lot of the babies were being fed on bananas. They were, once one baby was taken off the nipple, then they would get bananas, and that was what was leading to the yellow hair and all the problems that they had with the post, natal kind of treatment for the kids. And they've learned a lot of things that I think collaboratively you're already sharing some of that information. But they basically set up a farm right next to the clinic so they can show the people how to prepare better, more nutritious foods that the babies needed as they were growing up, as well as doing a lot of things with just local shaman to get more communication and buy-in from families to really do the treatments that they knew were necessary. And it sounds like you're aware of that project, and I think that'll be a really nice collaboration. And
Larry, I think Larry's aware of the project too. I had the benefit of visiting as well.
cool.
One of the other neat things that hospital does is they hospitalize women a month ahead of time to work nutritional issues before they deliver. And they have a mobile nurse program too that goes out to villages on motorcycles. So it's taking care out, a lot of public health kinds of care out to villages that way. I think Larry built on that sort of thing when they started getting the rural health team, getting motorcycles for the rural health team so they could expand their access out to the community. And I think if we can, and we really would like to, look at an insurance program, we're going to be going back to talking to Bwindi Community Hospital to see if we can model some of the things they've done. Because they really accomplished all that without any government support, is my understanding, until the last year when they began to get some government support.